Hi everybody, we're going to go ahead and get started on women's health, and the next one will be men's health. So really on this one it'll be talking about estrogens and progesterone. So those are the medications that are involved. The pathophysiology of again, this is part of the endocrine system. It's very complicated pathophysiology wise, but the medications are a little limited because we're really giving estrogens and progesterone. So as far as choices for that, there's not as many as, per se, some of the other systems like hypertension and diabetes, cardiovascular stuff. So, all right, so we're going to get started. I am posting a Khan Academy. If you have already watched it, this may help you get through this. I'm going to try to explain this in layman's terms as much as I can, because to me it's easier to explain it in layman's terms. Then you go back and you understand when they're talking a little bit more or intricately about each specific hormone, progesterone, inhibin, etc. Okay? So what I'm trying to say is that you have the ovaries and you have the uterus. All right? So think about the female and the male. When the fetus is developing, you're either going to develop ovaries or you're going to develop testes. All right, so that's the difference. So you have your ovaries and you have your testes. Those are to make a baby. All right, that's the main function of an ovary. We have to go through the cycle of having our period, menstrual period, etc., and those side effects from the lack of estrogen when we hit menopause. But really, the primary reason we have ovaries is for reproduction. And then we have the uterus, again, for reproduction. The uterus is basically a muscle that stretches for a fetus that's growing or a baby that's growing in your belly. So ovary and the uterus. So uterine changes are brought about under the influence of estrogens and progesterone. So when you think about the menstrual cycle or even the whole ovulation cycle that brings upon your menstruation because the egg is released, this is all about estrogen and progesterone, as well as a follicle stimulating hormone and luteinizing hormone. So if we look at the brain has the anterior pituitary gland, and that is what releases the follicle stimulating hormone and the luteinizing hormone. All right, so those will release, and that regulates the menstrual cycle. This picture is a little bit complicated. That's why I posted the Khan Academy. But basically what happens is, they usually these look like they're numbered. All right, this up here, it actually looks like testicles, but it's the anterior pituitary gland, so sorry. So here is the hypothalamus up here. All right, you see this? Because remember, everything's talking to each other, kind of like the thyroid is. You have the thyroid stimulating hormone from the anterior pituitary. It's talking to the thyroid, and all these functions and series of pathways go through your body with these hormones, chemicals, aka hormones. So we have the hypothalamus, which releases GnRH, gonadotropin releasing hormone. That goes to your anterior pituitary. Your anterior pituitary is responsible for releasing, the follicle stimulating hormone, okay, and the luteinizing hormone. Follicle stimulating hormone, if you see these here, these are your follicles. It's a follicle that actually ends up maturing. You go through ovulation, the egg's released. So as this follicle is growing, it's making an egg in the center, and all these follicles are being produced from the communication from the hypothalamus and your anterior pituitary. So it's releasing this, okay? And so basically think of this area, think of number 2 here as the beginning of actually the end of your menstrual cycle. You finish your period. And so what happens is your body's saying, oh, we have to start growing a follicle again because we need to make an egg. So this follicle stimulating hormone and luteinizing hormone gets secreted from the anterior pituitary. It starts growing, all right, and your estrogen level starts rising in response to that. Remember, for every action, there's a reaction. So these are released. It's growing. When the follicles get to a certain phase, your estrogen level rises, goes to the pituitary. All right, see it's rising here. And then what happens is your estrogen level gets so high, your pituitary gland is saying, oh, we better release more luteinizing hormone and follicle stimulating hormone. So then it comes over here and ovulation happens. So that's, according to the books, day 14. As we know that as women, it's not always day 14 and our period's not always on day 28. But for teaching reasons, this is average. Ovulation. So once ovulation happens, the egg's released, we know you're not going to get pregnant unless there was a sperm that met, and then that would be a different story. All right, so then in number 8 here, you start ovulating. Sorry, I'm skipping over my words, because to me this is more of a complicated pathophysiology, and this picture is more complicated too. Estrogen and progesterone and inhibin. We don't hear too much about inhibin, but think of it as inhibit. So what it's doing, it's inhibiting the follicle stimulating hormone and the luteinizing hormone. So think of that as inhibin it as that rises. Estrogen and progesterone then go up to here, which then again talks to the hypothalamus to say, hey, we need to release some of this. And the whole thing starts over. When you think of here, when it's stopping here, your endometrium is thickening. All right, so right here, your endometrium is what lines your uterus. So when it's thick enough, this is past ovulation, remember, because all these hormonal occurrences are happening. It's thick over here, and that's when you start shedding, and that's when you have your period. So as you can see, it's very complicated. So if something's happening in a woman's hormonal cycle, you can see how maybe people can have painful periods, heavy periods, breakthrough bleeding. So it's just a disruption in the cycle. So maybe they're not ovulating every single month, or the eggs aren't getting mature enough. I know you hear a lot about infertility issues, so there's a lot that goes into the cycle. So a lot of it is just some trial and error along with some science to try to figure out and try to solve the problem and where it's happening in the cycle, and see if we can help regulate the cycle or help things along. All right, so the ovary is the male principal organ in the female, and I already said that. The male would be the testes, which is discussed on the next one. And we have primary sex characteristics and secondary. So primary just means your reproductive organs. The secondary is what happens when you go through puberty. So puberty will just depend on genetics and growth and nutrition, activity. Multiple things will depend on puberty and exactly when that's going to start. Some people start puberty earlier, some people start later. But if we look over at the females, we all know that you get breast development, your uterus enlarges, you start your menstruation, pubic hair growth, your ovaries develop adrenal glands, or your ovaries develop more adrenal glands, you get hair, and then you start releasing. So the pituitary gland starts releasing these hormones that stimulates the ovaries. All right, so that's when you think of physiological, what's going on inside your body, these things are all happening. You're starting to get hair, you're starting to get breasts, because what's happening is the pituitary gland is starting to wake up and starting to release these hormones, and then you start your menstrual cycle. And so there we go through the process, and now you're able to get pregnant and have children. All right, and if you have not heard of it, they're called Tanner stages that you go through each system, like breast buds first, etc., and then you get the hair and that kind of thing. Men will get more of a voice change because their larynx enlarges. So again, we'll go through that on the next one. But estrogens have a lot of metabolic and adverse effects. So when we think of estrogen, yes, it's a hormone. It's no different than our hormone, the thyroid stimulating hormone. As you know, if you have too much or too little, you're going to have adverse effects, right? So estrogen also has some adverse effects. For example, what does it do in the brain? It helps to maintain your body temperature, helps against memory loss. So this is why I say the endocrine system is so intricate and so important. If part of it's off, it can really throw off how you feel as a woman. So as you can hear, people complain of hot flashes going through menopause. It's that lack of estrogen. You can have a lot of side effects to that. Okay, so the breast, what does it do? We talked about the puberty phase, and it also helps for future milk production. The one thing that I didn't mention, think about male versus female. Males have one area. They have the testicle area and penis area. That's one area. We have the vaginal area, your ovaries are in there, and then we have the breasts because it prepares, because really the breasts are for milk production, right? So that's the whole point of the reproductive system. The heart and liver. It's really important with the heart and liver because it regulates production of the cholesterol, decreases the buildup of plaque in the coronary arteries, which is why your risk goes up when you are postmenopausal, because your body is not secreting the estrogen like it once did when you were ovulating. When we say you're ovulating, postmenopausal, just by definition so you know, is someone who has not had their period, their menses, for greater than 12 months. So if you go 10 months without your period and then get one, you have to start the whole cycle over again. So if you're the average age of menopause is 52, and this is very genetic. Some women go through menopause in their 40s. A lot of it's genetic in their 50s. So just to give you an example, once you stop ovulating, which means think of the hypothalamus and the anterior pituitary stops talking, stops decreasing these luteinizing and follicle stimulating hormones, the estrogen stops decreasing, the cycle starts slowing down. And so right now, if you have a full functioning ovary, it's stimulating that whole cycle of the menstrual cycle. The vaginal area is really important because it helps we call it estrogenize the vaginal area. It maintains the lubrication and the thicker vaginal lining. So people that are postmenopausal have issues with atrophic vaginitis, which means atrophic means thinned out. So you have a thinned out vaginal wall. What's going to happen if your wall of the vagina is thinned out? It's right next to the urethra. The urethra can have issues too because that whole vaginal area starts drying out. If it dries out, you are at increased risk for getting bacteria in there. So that's why women have frequent UTIs. Elderly people do. You can have all sorts of issues. You can have, painful intercourse, frequent infections, though. Frequent UTIs are really huge with that. It helps preserve bone density. The estrogen does, and if you see me looking over, it's because I took notes. So it's really important to know that it helps preserve the bone density. Once you stop making estrogen, your bone starts decreasing dramatically, your bone mass. So when you think about Swiss cheese having holes in it, that's because your bones are breaking down. You don't have enough estrogen, because estrogen is very important in preserving that density in the bone. And which hence is the name osteoporosis, osteopenia, which is just say like prediabetes. Think of osteopenia being like the equivalent of prediabetes. The uterus, which stimulates the maturation of the entire uterus to help prepare it to develop a fetus. It helps adhere to the wall. If your lining is too thin, its egg is not going to adhere to the wall. Like some women have uterine ablations now. It'd be very rare, although it's not birth control, because you are at risk for a follicular pregnancy, getting into the follicle. I mean, oh my gosh, yeah, the follicular tube. Because what happens is if you have a thinned out lining of your uterus from an ablation, because women are having such heavy bleeding now, there's nothing for that egg to stick in, and so then it'll go into the tube, endometrial tube. That's what I'm trying to say, the endometrial tube. And it will develop there, and that can be a dangerous situation. So we always say you still need to be on some birth control. Okay, so that's the effects of estrogen, so make sure you understand that. But what happens when you go through menopause? What happens if you have a hysterectomy with your ovaries removed? You're not going to ovulate, right? Or if you go through menopause, you're not getting that estrogen anymore, so you're having hot flashes and maybe just not feeling well. Some people have a lot of issues with anxiety, depression, going through menopause, even postmenopausal. Hot flashes are very common because you have they're called vasomotor system. That's part of the vasomotor system, and you have symptoms of hot flashes. Those are really common. You are at increased risk for increasing strokes, TIAs, certain cancers, migraines, increase in triglyceride levels, gallbladder disease, and GERD, the reflux. And also, supplemental estrogen can cause false positive mammogram results. So, when you think of thromboembolic events, think deep vein thrombosis, stroke, and TIAs, trans-ischemic attacks, so mini strokes, hence that's the other name for it. So supplemental estrogen has its drawbacks. There's a lot of research out there on it. Majority of the population of females about 20, 30 years ago were on estrogen until a major study came out, the Women's Health Initiative study, and we were finding that women were having these cardiac events and issues like that. So then all of a sudden everybody's freaked out and started taking the women off the estrogen. Women feel, on the whole, most women feel much better on estrogen. So right now, the research is out. There's still some research coming out saying, okay, maybe it's not so bad, or make sure you're only giving it for 10 years and not for lifetime. It's the elderly population that ended up having more of the complications from supplemental estrogen. So it's a very fine line when we're prescribing supplemental estrogen supplements. I'm not talking about birth control pills when you still have your period, so we will talk about that too. So why do we use estrogen? We use it for menopause. That is the main reason why we use it, because menopause can cause many symptoms, which I had said on the recent slide. So I had mentioned already the cardiovascular disease, vaginal dryness, your bone mass, but also your hair becomes thinner, your teeth and gums can recede, that's when your breasts go south. If you ever hear, well, you guys are young, but when you get older, you'll start hearing about women complaining about their boobs going south, because that's what happens. Everything, like your skin just becomes drier, things lose its elasticity, so it's just not fun. Okay, so the other thing is if you are having no period at all, if you're amenorrheic, these are the symptoms on the right that you can have if you've not had a period. So we see this over perhaps in poorly developed countries, or females here that have anorexia nervosa or are super, super active. They can be amenorrheic. Okay, slide change. Let's see. Okay, there we go. All right, so hormone therapy. So there's two kinds of hormone therapies that we can use. One is the estrogen with progesterone. So if you have an intact uterus, if you have not had a hysterectomy, all right, so young ones that are ovulating, still having their periods, that's birth control pill. That's estrogen and progesterone. And then there's estrogen therapy. And those are for use for women that have had a hysterectomy or postmenopausal. You can use the estrogen therapy for, because they're not ovulating anymore. So talk about some of the medications. there are called SERMs, selective estrogen receptor modulators. Actually, let me move my screen up because I don't think you can see that. There we go. Okay, so what these do, they don't actually secrete, they're not actually estrogen per se, but you have estrogen receptors in your body during that whole cycle that we discussed before. And what this does is it becomes activated in some tissues and blocks the receptors in other tissues. So the SERMs were made to perhaps give the estrogen benefits, but yet decrease some of the side effects or complications of estrogen. But as you know, with every single medication, there's always going to be side effects. So the one most common one is tamoxifen. It's given for breast cancer treatment. It inhibits cell growth in the breast, so that's really important to know about that. It activates the estrogen, protects against osteoporosis, produces hot flashes, so this one can. And there's a risk for endometrial cancer and thromboembolism, so you have to be real careful with that. So one thing I really want you to remember is that the principal benefit of estrogen therapy is suppression of menopausal symptoms and prevention of bone loss. All right, so if you take one thing away from estrogen supplementation or giving this is for that prevention of bone loss and suppression of your menopausal symptoms. All right, so if we look here, this produces hot flashes, but there's a lot of other post-menopausal symptoms that you can have, so please take note of what I just said. There's also another one called Evista. This one doesn't activate the estrogen, works a little bit different physiologically. This one protects against breast cancer and osteoporosis, but it can induce hot flashes and promote blood clots. Here's another medication which I've actually never used or heard of it. It's called Duavi. It's estrogen and I'm not even going to say that word. Well, bazidoxifene. Okay. First drug to combine the estrogen with an estrogen agonist and antagonist. So working for, working against, agonist, antagonist. So what the second part of it reduces the risk of excessive growth of the uterine lining posed by the estrogen component. Because if you're taking estrogen, think about it, you could have a menstrual cycle, or you can it can thicken the lining of the uterus. Although you're menopausal, your body still needs estrogen for other things, but sometimes, although you're not ovulating anymore, you can still get a thickened uterine lining. So this drug will supposed to help prevent that. The contraindications are the same for other products containing estrogen, and remember, and take note of this, that these drugs should be used for the shortest duration possible at the lowest dose possible. So it's really tailoring it to the patient. Now, progestins are compounds or progesterone that act like progesterone. And this is what's produced by the ovaries and placenta. So progesterone, which I didn't really talk about too much in the cycle, progesterone is excreted as your lining of the uterus becomes thickened. So that's when progesterone actually starts climbing up. But progesterone has been used for all sorts of reasons. People with dysmenorrhea who are bleeding, having painful periods, that are having excessive bleeding. There has been thought that progesterone actually helps stop the bleeding. It just helps get that cycle back on track. It doesn't always work, but it's really first line for dysmenorrhea or menorrhagia. Menorrhagia is excessive bleeding. Dysmenorrhea is difficulty in menstruation. Your menstruation may be off sync, or you're having some painful periods. So progesterones are used in postmenopausal hormone therapy, dysfunctional uterine bleeding, amenorrhea, which is no period at all, prematurity prevention, and endometrial cancer and hyperplasia. So menopausal hormone therapy benefits. Relief of vasomotor symptoms. Remember, those are hot flashes. Remember management of the urogenital atrophy. Remember I said atrophic vaginitis. Your whole vaginal area just dries out completely. And then that puts you at risk for sores and irritation and UTIs and all sorts of things, painful intercourse. Prevention of osteoporosis and related fractures. Some say cardioprotection. Prevention of colorectal cancer, positive effect on tooth healing, tooth retention, and glycemic control. So if you go ahead and look back at the picture of all the symptoms that menopause can cause by having lack of estrogen, if you're replacing with estrogen, these are the benefits of hormone therapy. The main things, though, I want you to know is that the only reason we would give it, though, is for the menopausal symptoms, which would be your vasomotor symptoms, but particularly the bones. So physiologic doses of estrogen with or without progesterone, those are some more benefits. And we know that I already said it's taken to manage symptoms, which would be sleep disturbances. We talked about the atrophy, bone loss, your lipid metabolism, hot flashes. And then I already talked about hormone therapy replacement. We don't really use it as much anymore just because of the Women's Health Initiative. This looks like a repeat slide, so I'm not going to go through that. Okay, so what I'm going to go do now is go through my notes here and just make sure that I covered everything because, like I said, these are Dr. Vernon's notes. So I'm going to post the Khan Academy slides. If you're still having trouble just kind of understanding the cycle, it's not that easy, but just try to remember the medications. The medications are not as difficult because try to understand with the female that we make estrogen and progesterone, all right? The supplements are estrogen and progesterone, and there's reasons why we give those, because what happens when you're postmenopausal or menopausal, what are the symptoms you're getting, right? What happens in your body? Look at that slide of the picture of the woman. It shows all the issues. Then think about why would we give hormone replacement? So remember, if someone has had a hysterectomy, let's just say, I'll do a little case study. So let's see. You're teaching somebody who has had a hysterectomy, and they want to go on some hormone therapy. So you're thinking about putting this patient on hormone therapy. Now I'm thinking of a nurse practitioner, right? So you're the nurse, and this patient comes to you and says, I'm going on this estrogen supplement because I keep having these hot flashes, I have vaginal dryness, and I'm just not sleeping well. So what are you going to tell them? What's the best thing? That would be probably the best teaching method that you would tell them. So, do you think that you would tell them to take hormones forever? Would you say, you know, hormones are really good for managing your symptoms, so you can take the hormone as long as you want? So would that be an answer? Or by taking this estrogen, you're going to reduce your risk of having any cardiovascular disease. Is that a good answer? Or, I've had a hysterectomy, so I know that I need to take progesterone and estrogen in combination. Are you going to say that? Or are you going to say, it's really important to put you on the lowest dose, let's make sure you're on the lowest dose, and we'll keep you on it for a short time. We'll try to relieve your symptoms, then we'll have to wean you off of the medication. So if you chose the last one, that's the correct answer, because that's the best answer, because you're thinking about safety, you're thinking about the adverse side effects that the patient can have. So yes, it can reduce your risk of cardiovascular disease, but it's more of lipid metabolism, and there's a lot more studies out there about this, so I wouldn't be so definitive telling the patient that, and still the most important question would be to tell them you need to take it for the shortest duration, because side effects, whenever you're giving a medicine, risk versus benefits, the risks of giving the medication to somebody and the benefits. So sometimes the risks for taking it long term outweigh the benefits of it, so you need to take them off of it. Okay. Sorry I'm going so slow. All right, so let's see. Make sure you know your side effects of each of the medications. So tamoxifen, your raloxifene, which is your Evista. Try to understand exactly what's happening with these drugs. So for an example, let's talk about Evista for a minute. This one can cause the vasomotor symptoms, so it can actually cause some hot flash issues. So that's not a good thing, right? But again, it can cause some other positive things, so let me get to that. One here. There we go. This protects against breast cancer and osteoporosis. So a lot of people that have had breast cancer take Evista or they're on tamoxifen afterwards. But you can have an increased risk of a DVT, and it induces hot flashes, which would be your vasomotor symptoms. Okay, and let's see. What happens if you are on an estrogen and you get taken off of it? What happens to the hormone then? It leaves, right? Because you're not taking it anymore. So let's just say you're taking it as protecting your bones and then you stop taking it. What's going to happen? You're going to get dramatic bone loss because that is one of the main hormones that's helping keep your bones together. So that is that. Okay. Okay, and then the last thing is just make sure that you remember the risks associated with estrogen and progesterone therapy as well as estrogen therapy. All right, so again, you're weighing the risks versus the benefits, but sometimes we have to put patients on them for a short time at the lowest dose possible. It could be because they've had breast cancer and they need to go on that to protect that. That's with the Evista, the raloxifene, although we do see people with tamoxifen on that also. It's for breast cancer treatment because it inhibits the cell growth. So we'll see a lot of people on that. As well as osteoporosis. It protects against osteoporosis. So when you're going on these, even with the progesterone, it's still, since it has the estrogen component, it is still helping your bones. So it's increasing, it's maintaining or helping your bone mass density. It's not decreasing it whatsoever. But just remember when you're taking these, the risks that are involved in it, which is, oops, okay, well, where is it? Okay, so just remember, deep vein thrombosis, which is your thromboembolism, strokes, ovarian cancer, okay, and let's see, some of them are hot flashes, but I would say the main things that are huge risks would be your stroke, your deep vein thrombosis, and your ovarian cancer. So cancers, you don't want a blood clot. Blood clot can cause strokes. All right, so that's easy to help remember that. All right, so I think that's all I have for my notes. Women's health is maybe you can tell as I went through this, is not my absolute favorite. To me, it's complicated, but again, the medications are more simplistic. I don't really prescribe these medications just because really you're seeing oncology prescribe them with the breast cancer, and gynecology is usually prescribing these. When it comes to birth control pills, yes, I do prescribe birth control pills. I have a book in my office, and I really try to select the correct one for your symptoms. But in reality, many of the physicians would go to their closet and just pick out whatever samples they had. Here, try this one, try that one. But the other thing we're having is really insurance companies tell us what we can prescribe. So if someone's having acne and I want to go ahead and give them a birth control pill, let's say an orthotricycline low. Again, with birth control pills, you still want to go on the lowest dose. So I usually always do more of a low dose. Well, guess what? The insurance doesn't cover it. So I have to have the patient call the insurance company and give me a list of what's covered, and then I have to go and look from there. But again, there's so many birth control pills out there with this dose of estrogen, this dose of progesterone. This is higher, this is lower. This can cause breast pain versus this one. This helps acne, this doesn't. So there's so many different variables you have to look at with birth control pills. So again, I have a little chart and I will say, okay, why did this, for example, I have people coming and saying their birth control pills aren't working. They're having breakthrough bleeding or they're having more acne. So I will look up those symptoms and say, okay, they need to have a little bit less progesterone. Let's increase the estrogen just a little, or vice versa. And then my handy dandy chart will give me a list of what pills that are out there, and I just try to pick the one that's covered by their insurance. Doesn't always happen, but that's just how that is. We have to remember with birth control pills too, there are some concerns with them. If you have migraines with aura, if you have morbid obesity and you smoke, yeah, it's DVT. You have a risk for DVT and stroke, especially the DVT with a pulmonary embolism or a stroke. If you take birth control pills and you have migraines with aura, if you are morbidly obese and you or have a family history or a personal history of blood clots, and smoke cigarettes. Time and time again, I see very obese people smoking cigarettes on birth control, and I'm wondering, who put you on that? So you have to be really careful. I would not put someone on that. I would pick a different one, like a progesterone only, that doesn't have the side effects or the risks as involved as much as estrogen. Okay, and I will see you in class.